Hello everyone, I am Pallavi Purohit and today I am here to present on my thesis topic, that is investigating the role of type 2 diabetes mellitus in cancer development, which is a retrospective cohort study. So here is the agenda for today's presentation, characterizing the problem, then looking at research question and hypothesis, data collection, data analysis, results, limitations and implications of findings. So coming to the characterizing the problem, type 2 diabetes mellitus and cancer are both rising public health concerns contributing significantly to morbidity and mortality, with the prevalence expected to increase due to aging populations, rising obesity rates and sedentary lifestyles. In the past 3 decades, the prevalence of type 2 diabetes has risen dramatically in countries of all income levels. As of 2025, approximately 830 million people worldwide are living with diabetes, with the majority having type 2 diabetes mellitus. As of 2023, diabetes is the 7th leading cause of death in the United States. Similarly, cancer remains a major global health burden, with cases expected to rise significantly, particularly in low and middle income countries. In the United States, it is the 2nd leading cause of death after heart disease. So, according to the American Cancer Society's Cancer Facts and Figures 2025, published in CA, which is a cancer journal for clinicians, it is projected that over 2 million new cancer cases will be diagnosed in the United States this year, with an estimated cancer-related mortality exceeding 600,000. So, this diagram illustrates the relationship between type 2 diabetes mellitus and cancer risk, highlighting the key mechanisms through which type 2 diabetes mellitus contributes to cancer development. Type 2 diabetes mellitus alters the body's metabolism in ways that makes it easier for cancer to develop and spread. The main culprits are chronic hyperinsulinemia, hyperglycemia and inflammation. So, in type 2 diabetes mellitus, insulin resistance forces the pancreas to produce extra insulin, leading to hyperinsulinemia. Insulin not only helps regulate blood sugar levels, but also acts as a growth signal, pushing cells to divide and survive longer than they should. Additionally, insulin increases insulin-like growth factor 1 levels, which is IGF-1 levels, which is a hormone that promotes cell growth and blocks apoptosis. This uncontrolled cell growth and survival create an ideal condition for tumor formation. Chronic hyperglycemia occurs due to impaired insulin signaling and reduced cellular glucose uptake resulting from insulin resistance. Elevated blood glucose levels serve as an abundant energy source, fueling tumor growth and enhancing cancer cell proliferation and metastasis. Hyperlipidemia in type 2 diabetes mellitus fuels cancer growth by providing energy to tumor cells, promoting DNA damage through oxidized lipids and reactive oxygen species, and enhancing metastasis by altering cell membranes. Long-term diabetes triggers chronic low-grade inflammation, causing the body to release pro-inflammatory cytokines. These chemicals damage DNA, weaken immune surveillance and promote a tumor-friendly microenvironment. The outermost ring shows type 2 diabetes has been linked to an increased risk of multiple cancers. Coming to my research question, so does type 2 diabetes mellitus increase the risk of developing common and aggressive cancers such as liver, pancreas, colon cancer, endometrial cancer and kidney cancer? So, hypothesis is individuals with type 2 diabetes mellitus have a higher risk of developing these cancers compared to non-diabetic individuals. Although previous studies have suggested an association between type 2 diabetes mellitus and certain cancers, important gaps still remain. Many studies have been limited by small sample sizes, lack of diverse population and inconsistent control for confounders. Furthermore, much of the research has focused on individual cancer type rather than evaluating the broader impact of type 2 diabetes mellitus across multiple aggressive cancers. By leveraging a large-scale electronic health records dataset, this study aims to provide a more comprehensive and updated analysis of whether type 2 diabetes mellitus increases the risk of developing liver, pancreatic, colon, endometrial and kidney cancers. This research will help clarify the strength of these associations and contribute to future cancer prevention strategies in diabetic populations. I extracted data from the UCSD Health OMOPSIDIUM clinical data warehouse and used SQL queries to retrieve relevant patient records. This flowchart here represents the main structure of my SQL query, outlining the step-by-step process of data extraction and integration. It illustrates how I selected the study population, applied exclusion criteria, classified diabetes status, identified cancer diagnosis, extracted relevant clinical data, and merged all information for analysis. For the study population selection, I have identified adults who are above 18 years from electronic health records by calculating age from the birth date. Also extracted demographic data such as race, ethnicity, and gender, and then excluded diabetic patients who are prescribed with GLP-1 agonists to avoid their protective effect on cancer development. Classification of diabetes status. I identified patients diagnosed with type 2 diabetes mellitus from 2010 to 2020, ensured type 2 diabetes mellitus was diagnosed before cancer development to establish a temporal relationship. Identified the cancer cases using ICD codes and included only those cases which are diagnosed within 5 years of diabetes diagnosis to study early cancer development. For the confounders, I have extracted BMI, smoking status, alcoholism status, cardiovascular disease history, and for the data integration, I have merged all these into the final data set for analysis. So, coming to the data analysis, all data analysis was done using R programming. I used chi-square test to evaluate the categorical association between type 2 diabetes mellitus and cancer, then did unadjusted logistic regression to estimate crude odds ratios, and then adjusted for confounders, BMI, age, gender, alcohol use, CVD history, smoking status, race, and ethnicity. To assess multicollinarity among the selected confounders, I did variance inflation factor analysis, that is VIF analysis, and then plotted Kaplan-Meier curves to compare time to event differences between diabetic and non-diabetic groups, and then did the log rank test, then used Cox proportional hazard model to estimate the time dependent effect of diabetes on cancer risk, and then plotted forest plots to visualize the resulting odds ratios and hazards ratios along with their 95% confidence interval and p-values. So, coming to the results, this table compares the prevalence of different cancers between individuals with and without type 2 diabetes mellitus. The no cancer row show the total number of individuals in each group who did not develop the specified cancer. The cancer row shows the number of individuals who developed cancer within the study period, that is 5 years from diabetes diagnosis. The cancer prevalence column represents the proportion of cancer cases within each group. The chi-square p-value indicates whether the difference between diabetics and non-diabetics groups is statistically significant. Across all the cancers studied, the prevalence was higher in diabetics compared to non-diabetics with highly significant p-values. These are the results from unadjusted logistic regression model, which suggest a significant association between type 2 diabetes mellitus and all the 5 cancers. The table presents the odds ratios with confidence interval, and the forest plot visually represents these associations. So, these are the results from adjusted logistic regression. For all 5 cancers, the odds ratio is greater than 1, suggesting a positive association between type 2 diabetes mellitus and the cancer risk. As we can see here, the strongest association was observed for pancreatic cancer and liver cancer with odds ratio of 1.58 and 1.43, while the associations for colon, endometrial and kidney cancer are comparatively weaker but still statistically significant. The confidence interval do not include 1, further supporting these associations. In the adjusted logistic regression analysis, several factors beside diabetes were significantly associated with cancer risk. Age, smoking history, BMI and cardiovascular disease history were strong risk factors across multiple cancers. Smoking was linked to liver, pancreatic, colon and kidney cancers, while BMI was consistently associated with all the cancer types. To assess multicollinarity, I did VIF analysis, and all the predictor variables had VIF values around 1, which is below 5, confirming that multicollinarity is not a concern in this model. So, I plotted the Kaplan-Meier curves to visualize the time to cancer development in diabetic and non-diabetic individuals. This allows us to compare the cancer-free survival probabilities over time between the diabetic and non-diabetic groups. The red and blue lines represent the survival probability for diabetics and non-diabetics respectively. The results show that diabetic patients developed cancer earlier than non-diabetics, with the biggest difference seen in colon, kidney and endometrial cancers. For pancreatic and liver cancers, the difference was smaller. The drop in survival probability within the first 500 to 1000 days suggests that cancers may develop sooner in diabetics, highlighting the importance of early monitoring. I also conducted the log rank test to compare the time to cancer development between diabetic and non-diabetic groups. For all cancers, the p-value are extremely small, meaning diabetes significantly affects the time to cancer development after the diabetes diagnosis. Diabetic patients developed cancers earlier than expected compared to non-diabetics, with the strongest effects observed in liver and pancreatic cancer. In all these cases, diabetic patients had more observed events than expected events, confirming a higher risk. The Cox proportional hazard model revealed that diabetes was significantly associated with an increased risk of earlier cancer development for liver with the hazards ratio of 1.48, pancreatic with a hazard ratio of 1.61, colon cancer 1.17 and endometrial hazards ratio was 1.19. However, the association was not significant for kidney cancer, which is shown in the forest plot on the right. The model's concordance scores indicate good predictive ability with stronger performance for endometrial and pancreatic cancers, while liver, kidney and colon cancers showed moderate predictive power. The proportional hazard assumption held for diabetes, but was violated for the overall model, suggesting time-dependent effects in some other covariates. This indicates that certain risk factors may influence cancer development differently over time, potentially requiring stratified or time-dependent Cox models for better accuracy. As every other study, this study has some limitations. Selection bias. As this study is limited to patients within the UCSD health system, so findings may not be generalizable to broader population. Residual confounding. Despite adjusting for potential confounders, some residual confounding bias still remains. So, missing data, coding errors and inconsistencies could impact the accuracy of the analysis. Short follow-up window, that is 5 years. Only cancers diagnosed within 5 years were considered, which may underestimate the long-term impact of type 2 diabetes mellitus on cancer risk. So, causal inference limitation. This study demonstrates an association between type 2 diabetes mellitus and cancer development. However, due to potential residual confounding and the observational non-randomized study design, a causal relationship cannot be confirmed. So, coming to the implications of my findings. Clinical implications. Diabetic patients are at a higher risk for aggressive cancers, emphasizing the need for tailored cancer screening and early intervention strategies. The variations in time to cancer onset suggest diabetes-specific screening guidelines may improve early detection. Public health and prevention strategies. Managing diabetes through lifestyle interventions like weight control and glycemic regulation may also reduce cancer risk. Increasing awareness among healthcare providers and patients regarding the association can promote adherence to preventive screening programs. Coming to the research implications, the time-dependent effects observed in the Cox proportional hazard model indicate a need for longitudinal studies to better understand diabetes-related cancer progression. Policy and healthcare system impact. Integrating routine cancer risk assessments into diabetic management could enhance early detection. Multidisciplinary collaboration among endocrinologists, oncologists and primary care providers may improve comprehensive patient care. Thank you for listening.